traffic, which that's not a good part of it. Well, it's my colleague thinks of those things.
You can hear me. I don't want to stand in front of the podium the whole time, so if my voice starts getting low, let me know and I'll pick it up a little bit. Can you hear me okay? Great, great. Well, thanks for everybody for coming. I'm going to talk a little bit about the hospital and some of the good things we've been doing over the past couple years here. I want to start with our mission and our vision, these kind of things that we live by. Of course, our vision, to earn your trust and to be the first choice for your health care. And of course, the "your" in that is the community. We want to be the community's first choice for the health care here in Cibola County. Our mission is to provide excellent health care that our community is proud of by committing to, and we have 5 service pillars that we subscribe to, and I'm going to talk a little bit more about those later. But in our mission, under service, we want to create a hospital experience that exceeds the expectations of our patients, of our employees, of our physicians, and everybody else that we touch in the hospital. Under quality, we want to use national best practices. So we just don't want to do what the other guy next door is doing. We want to see what's going right nationally and implement those initiatives in our hospital. Under people, we want to create a purpose for worthwhile work so all employees can make a difference. So we want to make sure that our employees stay engaged and do whatever we can to keep them engaged towards patient care. Under finance, we want to maintain financial stability to ensure that we continue to meet the goals of the community or the healthcare needs of the community. So we're in this for the long term, and we want to make sure that we're financially stable for the long term. And under growth, we want to improve access to care through physician partnerships and other new services. Our mission and vision and practice, what we do as leaders of the hospital is we want to create an environment where the community wants their loved ones to receive their health care, where the physicians feel comfortable in sending their patients for their health care, and where employees enjoy coming to work every day, and when they leave, we want them to feel like they've accomplished something. So that's our mission and vision and practice. This is a sample of our board of directors. There's some of them that are here this evening. Paul Milan is here. Ron Ortiz, who's our board chairman, is here. Carlos Tapia, we're here somewhere, there, right in front of me. And Dr. Gutierrez is on our board also as chief of staff. Les Gaines wanted to be here this evening, but he had a prior engagement, he told me, with his job at Stewart Brothers. But our board is very engaged in what's going on at the hospital. Paul, I think, is the only one that's retired, but the other ones all have full-time jobs, and it's all voluntary. So all of our board members are volunteers. They give their time, their dedication to the hospital. We have some past board members here too. Ida Chavez is a past board member who was actually president whenever I was hired, so I appreciate her for that. Some other past board members are here also. So the board is, again, it's people of the community that are here working for the hospital as a community. We have 5 employed physicians here in town right now. These 5 operate or work in this building and in the hospital. We are working on, well, there's 4 physicians and 1 nurse practitioner. We are working to recruit physicians all the time. There's 3 physicians right now that we have under contract that are ready to start real soon. Dr. Okonko is the pediatrician who's replacing Dr. Onyama, and she'll be starting, she'll actually be in town this Thursday, and as soon as we get her work permit or J1 visa approved, which will be real soon, then she'll be starting her practice here in this building sometime before the end of September. We're hoping by around the 9th of September she'll be ready to go. Dr. Joseph Charles is an OBGYN who's practicing in Florida right now. He's been practicing for 10 or so years. He is coming to Grants. He's going to start his practice in January of 2014. And he'll be supporting Dr. Church, and they'll be working together with an OBGYN practice. Also, we have an internal medicine physician starting, Dr. Florentine. He is finishing his residency right now in Chicago, and he will be starting his practice whenever he graduates in July of 2014. So as you can see, we do our physician recruiting far in advance because physicians are very hard to find in this day and age. I read an article recently that said that New Mexico, the state of New Mexico, is short 300 physicians. So every hospital, every clinic in the state are competing for new graduates, for physicians that are disgruntled with where they are now and looking for someplace. So we look for a competitive advantage on what can bring physicians to Grants. And one of the things is this building. This building is really a great recruiting tool for physicians. We do have some visiting physicians that come from Albuquerque. New Mexico Heart Institute, we have a contract with that group that sends us cardiology. A cardiologist 2 days per month. Also foot and ankle specialties, send a podiatrist here. Sometimes once a week, sometimes 3 days a week, depending on what their patient volume is. We also have a new initiative we're doing at the hospital for telemedicine. We invested about $5,000 into a camera system in which the physician on this end and a physician on the other end of the camera can zoom in on the patient, see the patient, and make a diagnosis based on what they see with the patient, what the face-to-face physician is seeing with the patient, and what some of the studies they see that we can transmit through this technology. So right now we're able to do neurologists, and we have a cardiologist that's credentialed, and we hope we can grow that cardiology and some other services. And this is mainly in our emergency room where these patients are, where this technology is being used right now. Again, our ongoing physician recruiting, right now we're looking for a family practice physician or a family practice physician that has OB skills. Probably more of a family practice physician because we think that once Dr. Charles gets here that Dr. Church and Dr. Rocha, who also does some OB, and Dr. Charles and Dr. Church all together, the three of them, should be able to handle our OB volume. And we'll reevaluate that in the future, a year or so after Dr. Charles is here, and see where that is and see if it makes sense to recruit another OB physician. We have lost some physicians this year. We're having some difficulty recruiting some. So we did hire a locum, which is a part-time or a temporary physician. Dr. Leslie O'Connell lives in Albuquerque and works Monday through Friday, 9 to 5 here in our clinic here, seeing family practice physicians, and is nice and busy. We have her contracted through December with the option of maybe extending that contract, hopefully until our physicians come in the summer. We're also actively recruiting another nurse practitioner. Nurse practitioners can't operate independently in the state of New Mexico, so they are invaluable. Lisa does a great job for us now, and we're hoping that we can get another nurse practitioner that can also pick up some of our patient volume. We are on a journey of excellence. We've been on a journey of excellence now for about 6 years. What our journey of excellence is we've changed our culture at the hospital to become geared towards our customers and our physicians and everybody else in the hospital that we touch. So you see those 5 service pillars that were in our mission are also part of what we did in our journey of excellence. Some of the initiatives that we're doing with our journey of excellence on the growth, we're looking to build upon past successes and look ahead to the future as we continue to grow and mature as an organization. We're always growing, we're always maturing as an organization. No matter, we've been here since 1959. We'll probably be here for much longer into the future. So we want to plan on it and build upon those. Again, under people, we want to create an excellent environment for our employees to work, our patients to heal, and our physicians to practice medicine. Service, we want to provide excellent service to our community, our patients, our physicians, and our employees. Quality, we want to provide the highest quality of services. Again, we want to use national best practices. We want to judge ourselves against what's going on in Baltimore, what's going on in Seattle, and also what's going on in Gallup. Everybody. So we want to look at best practices all over the country. And again, under finance, finance always plays a part in it. We want to make sure we do things financially sound. We want to make financially sound decisions because we are in this for the long term. We want to make sure that we're here financially for the long term also. Some of our customer services initiatives that we've done, we subscribe to the Studer group, which is a nationally renowned group that specializes in helping hospitals and healthcare organizations meet the goals of their community through customer service initiatives. We always use evidence-based customer service practices. So the things that we put in practice in the hospital have been tested for years by other hospitals, and we just kind of copy or steal what they do, modify a little bit so it makes it work for us, and implement it. We have on-site training. We have a coach's call with a professional at the student group that helps us weed through what works in other places and implement here. Some of our initiatives that we've subscribed to, or we always have done and do more of, we never place blame on a person. If something goes wrong, we want to make sure that we look at the process, because somewhere in that process, something broke down. We want to make sure that people aren't scared to tell us when something goes wrong. So we make sure that whenever something does go wrong, we don't point the finger at somebody, say, you're fired, you're out here, we don't want that to happen again. We look at the process and make sure people understand their roles in those processes so that things do work properly. We also, of course, we treat everybody in the hospital with respect all the time. Some of the proven initiatives that we do, leader evaluations, we do those on a high, middle, low, and on a leader evaluation model, the LEM. So we have concrete goals that we set for our leaders that they have to meet in order to get a good evaluation. ADEC is a customer service initiative where it is how we communicate with our patients. So if you come into the hospital, we hope that the employees follow ADEC, where they introduce themselves, they tell what tests they're going to take, how long these tests are going to take, what to expect during the test, those kind of things. So it's a kind of a subscribed way for the employees to remember what to say and how to say it to the employees or to the patients. Whenever we see something going right in the hospital, our leaders send out thank you cards to those employees to kind of reinforce that behavior that we want them to do. We keep our leaders informed on what's going on with best practices. We do what we call LDI, Leadership Development. Every quarter we get the leaders together and we put on a program to teach them customer service initiatives, management skills, those kind of things. So our training of our leaders is constantly ongoing. We also implement something in the hospital called a 5-10 rule, which the goal is to create a friendly environment for our people. So the rule here is if you're walking down the hall and 10 feet from somebody you make eye contact, and 5 foot from somebody you're saying good morning or good afternoon or hello. So it's just a way to build that friendly environment within the hospital. And manage up, what we do with manage up is we teach our people that when things go wrong, again, not to place the blame, but to build up the other area in a positive way. We do a lot of surveys in the hospital. We survey our patients, both inpatient and outpatient. Our inpatient surveys are called HCAHPS. HCAHPS are subscribed to by Medicare. So the CMS program outlines the HCAP questions and have the hospital ask these questions. We do it through a company called Press Gaming. And Press Gaming will call our patients 4 to 6 weeks after they're discharged and go through these series of questions. These are the same questions that are asked by hospitals all across the country. So these questions are the same no matter where you are. We also do outpatient satisfaction, same way. Press Gaming calls the patients a couple weeks afterwards, asks them questions, same with the ER. We do physician satisfaction and employee satisfaction every year because we want to know how the physicians, how the employees feel that the hospital is treating them, if there's any way that we can improve how we treat or what we can implement to help keep our physicians and our employees happy. HCAP scores are posted periodically on a website called Hospital Compare. That's CMS's website. And this is a sample of what our HCAPs look like. And I'm going to blow this up so you can see where we are. We are the green on this graph. The yellow is all the hospitals in Press Gaming database, or all the hospitals in a database of CMS. The orange is all of Press Gaming's database. The purple are the smaller hospitals in Press Gaming's database. And the AHA Region 8 is the New Mexico, Arizona, Texas hospitals. So as you can see from this graph, we are the green and we are far above a lot of the other hospitals in the nation in a lot of these initiatives. The first one is the Rate Your Hospital on a scale of 0 to 10. We are around 75. So 75% of the patients answered always that our scores are within 9 or 10 on a scale of 0 to 10. Recommend your hospital. So about 85% of our employees would recommend our hospital to somebody else, whereas you can see the rest of the country is hovering around 73 or so percent. Our patients think that our nurses communicate well with them. We're far above those rest of the hospitals also. Same with the response of the hospital staff. And I'll talk a little bit more about some of the initiatives we put in place to keep that communication going. The patients also think our physicians communicate well with them while they're in the hospital. Hospital environment is made up of the cleanliness of the hospital and the quietness at night. So we have some work to do there, but we're still above a lot of the hospitals in the country. Same with pain management. They asked the patients to rate how their pain was relieved during their inpatient stay. And we're pretty much in line with the rest of the hospitals. We have some initiatives there too. Communications about medications, we're far and above. We're doing quite well according to our patients on communicating what their needs are with their medications. And discharge information, we're lacking a little bit, but we do have some initiatives in place to build that up also. Maria and Glenna, our CNOs, do a great job in keeping our staff informed on how to do this and keep them focused on where we are with our initiatives. Let me bring the slideshow back up here. So some of the initiatives that Maria and Glenn and the executive team have put in place, focusing on quiet at night to make sure that not only our nurses, but our x-ray techs, when they come on the floor, lab techs, everybody is aware that there's patients in the rooms that are sleeping, even if it's during the day, because they may have had a rough night or whatever. So whenever our employees are on the nursing floor, we want to make sure that they keep their voice down, or other things like noisy, squeaky chairs, carts, those kind of things, that we're aware of those and we get those reported and fixed. Discharge instruction project, we want to make sure that whenever the physician prescribes that it's time for the patient to go home. There's certain orders that the patient goes home on according to the physician. The nursing staff sits down and makes sure that the patients are well aware of how to take care of themselves, or that their caregivers know how to take care of them once they leave the hospital. Medication education, we want to make sure that our pharmacists are going to the patient room, talking to the patients, making sure that they know how to take their medication, that they're not just taking their fistful of pills first thing in the morning when they get up, that some they take in the morning, some they have to take with food, some they take in the evening before bed or whatever. So we want to make sure that it's crystal clear that our patients know how to take their medications whenever they leave. Leader rounding, Maria and Glenna do a great job. They go into the patient rooms and they talk to the patients, make sure that their needs are being met. We have communication boards hung up in the room so the patient can see who their physician is, who the nurse is that's taking care of them, and some other information that they would need to know. We even have our housekeepers going into the rooms and talking to the patients and asking them if their room is clean enough, if there's anything they can do, if their bathroom is clean enough, those kind of things. We do a lot of other, we do bedside reporting, which means that whenever the nurses change shift, that they're talking to each other in front of the patient, so the patient is engaged and aware of what's going on with their care, and they're hearing the same thing that the next nurse that's coming on shift hears, so that there's always open communication with the patients. We did a lot of, we're always upgrading our services and mainly our equipment. Always, every year we have a capital budget, and those are some departments that we focus on whenever we increase or we change equipment. Radiology, we invested a lot in radiology over the past couple of years. We started a new service in 2010 for bone density that tests for osteoporosis, so the patients didn't have to go to Albuquerque to have that test done. We upgraded our CAT scan. We have what's called a 64-slice CAT scan, which means that the patient goes into the tunnel, and every time the X-ray tube goes around one rotation, it's taking 64 pictures in an instant. So there's hundreds of pictures that are generated from that, and gives the radiologist quite a lot of views to look at to make sure that we do the right diagnosis. Also, with our 64-slice scanner, this year we purchased some software and upgraded some hardware with it so that we give a lower dose of radiation to the patient. Up to 60% less radiation our patients are getting, and they're also getting much better, much clearer images with lower radiation. The CAT scan we bought cost $489,000, and the upgrade for the lower dose, the AIR, is it called AIR, Terry? The software package?
Acer.
Acer, okay, thank you. That cost $178,000 to implement. That also in 2010, I believe it was, 2009, we purchased a digital mammography. That was with help of the county. The county paid up about $300,000 towards that purchase. The significance of this is that it helped us, it was the last piece for us to be able to go 100% filmless. So instead of having the picture taken on X-ray film, running that film through a processor, and the radiologist or the doctor having to flip it up on the light screen, it's all digital, so it comes through the computer and they can read it on the computer screen. And the big significance of this is that we can send these images anywhere in the world over the internet, and a radiologist or a specialist on the other end can make a diagnosis on that same picture. So we're able to we have a radiology group in Albuquerque that reads our X-rays for us during the day. We have a radiologist here twice a week, and then in the evenings and on the weekends we send them to a company that, I think they're in California, and they do our after-hours readings for us. So some of the other capital purchases that we've done are up there. Again, the county was gracious enough to give us $300,000 back in 2009 to do the digital mammography. That total project cost us $364,000 in 2009. We also recently just upgraded our mobile MRI. We have shared imaging, brings a mobile unit to us twice a week, Wednesdays and Saturdays. We chose Saturdays to do MRIs for the convenience of the patients. This keeps the patient from having to take a day off during the week of work to have their test done. They can schedule it quite easily on a Saturday. We've hired our own techs, so we're kind of divorcing ourselves a little bit from shared imaging with the long-range goal of having an MRI in-house at some point. MRIs are super expensive, probably $3 million to implement that service. So that's why we do it twice a week with a mobile. It's much more cost efficient for us to do it that way. Once our volumes come up, if they do ever come up, then we would definitely look into doing a in-house MRI, 24 hours, 7 days a week. So the digitizer is what helps us with some of our other older machines that we need to send digital images. We use it for the digitizer. We also purchased last year a state-of-the-art ultrasound unit that's used for OB patients. So Dr. Church uses it a lot with her pregnant women. And we also can do other images on it with abdominals and other things. That machine cost $128,000. So I want to talk a little bit about some of our financials, or where we are financially with the hospital. This graph shows charity and bad debt. These are the patients that are unable to pay their hospital bills, and what we do to help those patients. Over the last 5 years, our charity care are patients that meet indigent care that we are able to write off under charity. And as you can see, those patients, that increased from $904,000 in 2009, and right now in 2013 fiscal year that just ended, we did $1.5 million worth of charity care in the hospital. That's inpatient, outpatient, and all together. Bad debt are patients that come for care but are unable to pay their bill or don't pay their bill for whatever reason. In 2009, it was the bad debt was $2.6 million, and in fiscal year 2013, it rose to $4.3 million. So we're giving away a lot of care to our community, and it's not just us. These trends are happening nationwide. Nationwide, both charity care and bad debt. That says bad debt. It shouldn't say bad debt. I just noticed that. Are going up. They're going up nationwide, and these are some things that the hospitals are having to deal with. This is some of the major capital equipment we bought in fiscal year 2009. Total is some of the major things we did, but total we reinvested almost $946,000 in the capital equipment. In fiscal year 2010, we upgraded a lot of equipment also to the tune of $2.78 million. 2011, this is the year we started building this building, the medical office building. So a lot of our capital expense went to construction and equipment of this building, but we're still able to buy almost $800,000 worth of replacement and new equipment in the hospital. 2012, we were finishing this project, moving into this building, and we still spent over $1 million of capital equipment into renovations and also new equipment in the hospital. Then fiscal year 2013, it just ended. We spent $749,000 on new equipment and renovations to the hospital. Renovations to the hospital are always going to be ongoing. Even though it's a 12-year-old building, we need to keep it modern, keep it looking good, so we're always trying to reinvest money back into the building to keep it up to date. This is our 2014, I believe. Yeah, this is our 2014 capital budget. So we're planning on reinvesting $1.6 million back into capital equipment and renovations to the hospital. And you can see there's a little R next to some of those things. Those are replacement equipment. So some of the things that are old that we're getting rid of, we're replacing with newer technology to the tune again of over $1.6 million. What we did in 2011, we converted to a critical access hospital. Critical access hospital is nothing more than a designation by CMS, Centers for Medicare and Medicaid, on how we can bill and how we can receive reimbursement from Medicare and Medicaid patients. What we can do with those patients is we can charge them our cost plus 1% is what Medicare pays us. So in 2008, 2009, the hospital board had a vision and they applied for critical access hospital status. And a couple other things with critical access, hospitals have to be under 25 beds or less, which we are, and I always have been. Our length of stay over a year has to be less than 96 hours or 4 days, which it is. I think our length of stay now is 3.2 or something like that. So we're well below that. So we really didn't have to make any operational changes to convert to a critical access hospital. It's simply the way that Medicare reimburses the hospital. So in 2009 or 8, they applied for it, and CMS denied that because the ACL hospital is within the 35 miles. So to be a critical access hospital, you have to be 35 miles or further from the nearest hospital. Well, our board took exception to that ruling because the Native American hospitals are exempt from Medicare, and they're not really seen as a Medicare hospital, so they should not have been part of the calculation to be a critical access hospital. So our board appealed that decision to CMS and lost the appeal. And in 2010, they appealed it again, but the board didn't really want to invest because lawyer fees were hugely expensive. But the law firm that we used out of Washington, D.C., and the name is escaping me right now. You remember who they were, Jeff?
Rodney? Dickerson or something like that?
Yeah, they're a renowned Washington, D.C. Law firm. And they said, well, you guys are getting it from Medicare because you really should be a designated critical access hospital. Because what that means, it means an extra $1 million to the hospital, the bottom line. So the law firm took it upon themselves to continue the fight for us. And eventually we did win in 2011. We did win that appeal, and we were able to become a critical access hospital. And CMS also let us go back to 2009 and rebill all that to Medicare to the tune of about, to our bottom line, close to $3 million. So with our board's vision and the way they kept with it, we were able to get critical access hospital status, add $3 million to our bottom line, and also as time goes on, every year it's going to be worth $1 million plus to us in the future years. So critical access hospital status didn't change anything with our operations except for to add $1 million a year to our bottom line. Another thing we've done was Congress had an initiative where they wanted hospitals to use our computer systems to the fullest extent. So they have separate stages where hospitals have to prove what's called meaningful use of their computer system. So every time that a hospital reaches a meaningful use step, then that means enhanced reimbursement that Medicare and Medicaid will give those hospitals. We made stage 1 of meaningful use in 2012, and we're working on stage 2 right now. But the caveat to that is if hospitals don't do it, then they have to take a hit from Medicare. So instead of getting enhanced reimbursement, they're getting docked reimbursement. So it's really an initiative that Congress is kind of forcing hospitals to computerize. And their vision is for if a patient is here in Grants and they travel and they end up getting sick and they're in Baltimore, then they can pull out that patient's record that they have here in Grants in Baltimore, know exactly what went on with that patient, and be able to do the right treatment. That's the long-range plan of the government in their meaningful use for hospitals. So we've embraced that, and like I said, we've tested meaningful use stage 1, and that meant an increase of $500,000 to us. So we received $333,000 of that, and we're still waiting for CMS to give us the other $175,000. Once we do meaningful use stage 2, that'll be another so much money that yet to be determined once we reach that. And we're probably looking at spring or summer of next year in order to reach stage 2 of meaningful use. Any questions about that? Does it make sense? This is a list of our payers as they are right now. This is a pie graph. This is a graph by revenue, the same thing. And as you can see, Medicare and Medicaid are our two biggest payers. So that's why it made sense for us to convert to a critical access hospital so we can receive that enhanced reimbursement from our biggest payer group. The third, as you can see, payer group are the people that are uninsured, that don't have any insurance, and pay their bills out of their pocket. So that's quite a bit of a hit for this small community to be our third biggest payer to be uninsured. Then next is Blue Cross, and then Presbyterian Medical Group is our next biggest payer, to the tune of about close to $4 million is what we get from Presbyterian. Now there's been some talk about us not taking Presbyterian insurance, but in fact we have been taking it for several years. What we found out was that there was a Medicare Advantage plan called Presbyterian Senior Care that we did not take. And Presbyterian Senior Care is kind of a product that's sold by Presbyterian for people who are on Medicare, that instead of having Medicare, they use this insurance. So basically Presbyterian subscribes to these patients, and then Presbyterian bills Medicare. So they're kind of the middle person with between Medicare and their patients. We recently are now subscribing to Presbyterian Senior Care. We want to take as many payers as we possibly can. However, the payment from Presbyterian Senior Care was so poor that we decided that it wasn't in our financial best interest to take those patients, because they wanted to pay us 18 to 30 cents on the dollar. So for a patient that had Presbyterian Senior Care, we would have lost lots of money on those patients. So we made, the board made the decision that we didn't want to lose any money. However, whenever we became critical access hospital, that put us in a whole different status with these Medicare Advantage plans. So Presbyterian, we negotiated with them, and other hospitals in the state were having some trouble getting Presbyterian Senior Care plans also. So there's about 5 hospitals in the state that contracted with a contractor out of California that negotiated Presbyterian Senior Care for us. And now we are getting ready to take Presbyterian Senior Care as soon as they send us the contract, and they'll pay us about 55 cents on the dollar, which is much better than the 30 cents. So we will at least be able to break even with these patients now. So we're gearing up to take that as soon as we get the contract. And then some of our other payers are listed up there. We do some with the prison systems here, and Loveless and some others. This shows some of what we do locally with our local vendors. We put about $1 million back into the local Grants, Milan, Cibola County into the back into the finances of that area to the tune of $1 million a month. So we do give preference to our local vendors, and we do make a conscious effort to reinvest back into our community. Our annual employee salaries are almost $11 million a year. 49% of our operating expenses are spent or reinvested back into the local community. Some other initiatives that our nursing department is doing, bedside reporting. I talked about a lot of these things, but we do have a great staff that are conscious of the patient and always aware of how to take care of the patient better. Again, Marie and Glenna and the nursing staff really do a great job, along with lab, x-ray, and the other services. Really are conscious to take good care of our patients. One of the things that we did do an aggressive fall reduction program in the hospital that reduced our falls quite a bit from the previous years, and we're way below the national standards in our falls. And we'll continue those initiatives. Some other things with nursing care, we do something called hourly rounding, which means that our nurses are in those patient rooms every hour checking on the patient. And that's part of, number one, to assess the patient to make sure that they're still okay. If they need to get out of bed, we want to control that. So we go in and proactively check and ask if the patient has to use the restroom, or if they need to get up, they want to get on the chair. We don't want them reaching for the phone or reaching for something where they might fall out of bed. But check on them and make sure that their needs are met at least every hour. And what this does is it cuts down on the nurse call. So whenever the patient has to hit the nurse call button, they do that a lot less because the nurses are in there checking on them proactively. Really helps with fall reduction and with patient care. Some other things we do, we provide car seats to newborn families that need them, that don't have them. We want to make sure that the babies get home safe, and they keep that car seat so that ongoing, as long as the baby needs it, it's theirs. We do birthing classes, a lot of prenatal care. We're always looking at how we can improve and how we can do better with our patients. We're currently implementing a new electronic medical record for our emergency room so that we can help meet meaningful use in the future, and also automate our emergency room to keep the patients moving in and out as quickly as we can. Our nurses are very qualified and caring. We do a lot of education for not only our nurses, but all of our staff. Again, we use national best practices on doing that. A lot of the things that Maria and Glenna are doing with our patients our employees is advanced cardiac life support, pediatric life support. We also have a progressive critical care nurse program, which our nurses are being trained for critical care, so that whenever we do get our internists in the summer, that our nursing staff will be up to snuff. We'll be able to take care of those higher acuity patients with ease. A lot of other things we're doing with our nursing staff. We can see that our average patient ratio, CGH is us, we have one nurse for 4 to 5 inpatients, basically. You can see some of the other ones in Las Cruces. One nurse is taking care of 7 to 8 patients. Same with Espanola Hospital. General Hospital, 6 to 7 patients are being taken care of by one nurse. Same with Loveless or Presbyterian. So our nurse to patient ratio is a lot better. So we give a lot more personalized care to our patients with that hometown touch that we like to say we do. Our surgery department, headed by Dr. Gutierrez, does a great job for us, has been for a lot of years. Does a lot of general surgery, does upper and lower endoscopy, bronchial scopes. We also, Dr. Church does a lot of OB, GYN surgery. Very skilled surgeons, both of them. We also have pediatric dental surgery, which is kind of a niche that our hospital does. We have 3 pediatric dental surgeons in town that take care of those patients, and we do have quite a good volume pediatric dental surgery. We do have a podiatrist that comes who does some surgeries also here in town. We also have a second surgeon, Dr. Pendrak, that's been here for about 8 or so months, that is building his practice and is doing quite well so far with general surgery and endoscopy. Our hospital is accredited by the Joint Commission. The Joint Commission is a national organization that focuses on credentialing hospitals. They're nationwide, so the criteria that our hospital follows with Joint Commission is criteria that's followed by hospitals all across the country. It's all the same criteria. Ours is focused on critical access hospitals. So the critical access hospitals in Florida and other states are using the same criteria that we use with our hospital. Whenever we converted to a critical access hospital in 2011, the Joint Commission saw us as a brand new hospital. So they came and they did a survey as a new hospital. And we passed that survey, but they found some very small things that we needed to correct, which we did. And part of that was they needed to do a follow-up survey in 2012, in 1 year, which they came back and did that survey and found some very, very small things that we needed to fix. But for the most part, we breezed through both of those surveys with ease. Our staff did a great job. It's a 2-day survey, so they send a physician to quiz the employees and to follow a patient. They do what's called a tracer. So if a patient is an inpatient, they pull that patient's chart. They follow the patient, all the services that patient had, inpatient, radiology, if they had lab tests. They check, and they do the personnel, so they pull the personnel files of the x-ray techs to make sure that they had the education and the training that they needed. The lab techs, the same thing. And then they send somebody who checks the building for life safety. So they kind of look into our ceiling tiles and make sure that our firewalls are intact. They look at our emergency preparedness to make sure we did the drills the way we needed to. Just a whole array of things. So these 2 days are pretty intense. The whole staff is pretty on the edge, and you can see Maria and Glenna, their hair is sticking straight up because they're just running around all over the place, and the secretary and steward are making sure things are just right. And again, we did those 2 surveys, and we did excellent on both of them. So it's really an applause for our staff. And again, those are national best practices, national patient safety goals that we follow. And those are things like the Joint Commission has these national patient safety goals to make sure that we do the right lab test on the right patient. So if you come in and you have a lab test, the lab tech might ask you your name and your birth date or some other kind of, they want to know 2 distinct identifiers to make sure that they're doing the right test on the right patient. So if somebody asks you your name and your birth date over and over again when you're an inpatient, it might be annoying, but they just want to make sure that they get the right patient, they do the right test at the right time. That's some other of the national patient safety goals. We monitor those. Our board of directors gets a board dashboard every quarter that has not only how we are doing with our national patient safety goals, but how we're doing on about 50 other matrices. So there's a lot of things that our board is looking at every quarter, and we compare those again to national standards to see how we're doing, how we stack up against the rest of the country. A lot of the quality measures that we're doing, surveying our infection control to make sure that when patients are getting care in our hospital, that they're not getting an infection while they're here. So we watch those rates to make sure that we're low, and we're super low compared to the rest of the nation. The rest of the nation, 6.7% of the time there may be an infection happen in a hospital. Cibola General Hospital's infection rate is way less than 1%. So we're great. Surgery and inpatient ICU, those things. Our patients hardly ever go home with any kind of an infection. Also, we monitor the time in our ER rating area, the time that the patient is checked in to the time the patient either is discharged or goes to another level of care. We monitor that and we compare that to our national standards also. Our laboratory had a couple unique surveys last year, and Stuart's our lab director here. We had a survey from a company or an agency called CLIA, which is a federal law. CLIA stands for the Clinical Laboratory Improvement Amendment, where they send people out to accredited hospital and clinic laboratories. We had this CLIA inspection in 2012, and they came back and they found hardly anything wrong in our lab. So CLIA is part of the National College of American Pathologists oversee the CLIA program. And they said, they passed this and they had hardly anything wrong. Something must have been wrong with that survey. So CAP sent a team of five or so lab people here, and they went through our lab with a fine-tooth comb, verifying what CLIA did a few months earlier, and they couldn't find hardly anything wrong in the lab either. So we had two very strict, very stern laboratory inspections in 2011 that found almost zero things wrong in our lab. So that's really a credit to Stuart and our people in our lab. We successfully did both in the same year. And over 95% of the tests that are ordered by our physicians are done in our lab, done specifically in our lab. Some are sent out, some of the more expensive, the lower volume tests are sent out, but for the most part, we're doing a lot of the tests within our lab. Some other things that are going right, our HCAP scores, our inpatient scores, are trending upward, as you saw. They are getting better compared to national standards. Our patient files are far less than 1%, far less than the national standards, national benchmarks. We have an initiative right now where we want to get our young people in high schools interested in being medical professionals. So we have job shadowing. We do a couple other things I'll talk about also. Right now our med surge is fully staffed +1. So we have hired some new grads, and we've increased our staff because we want to get them trained. We want to get them moving into these specialized areas where we have some contract labor. OB and surgery are two areas that we have agencies, so we have nationwide companies that send us nurses. Very expensive, so we have a grow our own program where we're training these nurses on the job and to move those into those specialty areas to decrease our need for agency nurses. Part of being a critical access hospital, we're now able to offer a skilled swing nursing service, which means that in the past, if a patient didn't meet inpatient criteria, if basically the insurance company said they were ready to go home, but they still needed to have dressing change, they needed to have physical therapy or some other kind of a service, we had to discharge those patients to a nursing home for them to get that specialized service. Now we're able to keep those patients here and bill Medicare as a skilled patient. So that saves the family, saves the patient the stress of having to be transferred to another facility. We can take care of those patients here in the hospital for a much longer period of time. Some of the things that we do have 166 full-time and 10 part-time employees, and then 20 that are casual that kind of work, called PRN, that we work as we need them. The scholarships, we've been giving out scholarships for quite a year. We've given out 27 scholarships over the years. 18 of those scholarships have been completed. Some of the students do drop out or change or do whatever. But 13 of them were completed and were hired by the hospital. So we've reinvested into our community through scholarships, and we're able to keep those employees, those people here in the community and hire them. 11 as nurses, 1 is an ultrasound tech, and 1 is a radiology CT tech. So we are reinvesting into our community through scholarships. We also do a partner with New Mexico State University here in grants. We invest $80,000 a year into their nursing program. And it reaps rewards by we were able to get those nurses, when they graduate, we hire them. Keeps us from recruiting from outside of the area and gives us qualified employees in our nursing program that we can train into other areas also. Part of that also is job shadowing that we do in the hospital with our high school students. We do a community-wide health fair every year. We've been partnering with Continental Divide with Robert and his group for the past couple of years during their annual meeting, which really has boosted both their annual meeting numbers and our health fair numbers. And a big thing we do is we do blood screens to the community for free during those health fairs. We also do sports physicals where every year Dr. Gutierrez and Dr. Valdivia would line up the kids that needed to have their sports physicals in their office. We would support that with other staff at the hospital. This year we started doing them here in this clinic. Very good way to flow the kids in, get them their physical and flow them out. So we're going to continue that in the future also. I think that's my presentation. Any questions or any comments? Thank you. Any questions? Ryan, want to add to it?
Well, I'd like to say a couple of words. County is wanting to go out for an RFP here in the future, and we're wanting to keep the contract with Cibola General. And you could really help us by calling the county commissioners and telling them that you're happy with what the hospital is doing, where we're at financially. We're up to date on equipment. We're sound in almost every area of the hospital. And we need a lot of support to talk to the commissioners and let them know that we're happy with Cibola General. So, that's what we're up against right now is that they want to do a new RFP and go out. And I believe there's probably 3 or 4 that will probably respond to that bid. And we're hoping that Cibola General continues to take care of the healthcare for the county, the city, and the village, all our community members. So again, I know I'm going to repeat myself, but you could really help us by getting a hold of the commission and let them know how you feel. I hope you feel like we do. I feel like we're doing a good job at the hospital. Our administration, our people that work for us are doing a great job. We're happy with everything that's happening. So again, if you can help us by doing that, we appreciate it. Okay. You can report.
What's their purpose of doing that? What is their benefit?
Well, not sure. But the way it works is that the county owns the hospital, owns the building, owns the operations of the hospital. They contract that and contracted that out to our board. The board of directors is a nonprofit board of directors that is, its sole purpose is to operate the hospital. at the pleasure of the county. So the contract is up in February 20th of 2013. So the county's thinking is that they want to see what else is out there. Is there another entity out there that can operate the hospital better, more efficiently than what our board can? Can they bring better services to the hospital or to the community than what our board can? Can they better recruit physicians to our community than what our board can? So their thinking is that they just want to see who else or what else is out there that might be able to do what our board is doing better. Yes, ma'am.
Are the current hospital board members, are they paid for their time? It's volunteer or what?
It's 100% volunteer. So all the board members, they come to the meeting once a month. It's the last Monday of the month, the fourth Monday of the month. And they also have committees that they're on. So there's 4 or 5 committees. They might be on 1 or 2 of them that they serve on. So we try to have these, like I said earlier, all of our board members, I think for one, have full-time jobs that they're supporting themselves with. So we understand that, and we plan our meetings at lunchtimes or in the evenings to make it as convenient as we can for the board members. Board members put a lot of time in. Now hospital operations are a different animal than running any kind of another business. The way hospitals are billed or paid are completely different. Operations are completely different. You have all kinds of dynamics with physicians and everybody else that are in that. And it takes a board member at least a good year or so, isn't that right, Carlos, to understand, even some of the acronyms that are thrown out, some of the medical ease that people say during the meetings, how to read the finance reports, what is quality in a hospital? How do you read quality in a hospital? How do you measure it? Those are things that our board members have to learn. QHR Quorum is a company that our board of directors contracts with to help with management and the operations of the hospital. I'm an employee of Quorum, and so is Jeff, our CFO. And Quorum puts on these board presentations every year, board essentials, where board members can go and get this education along with other board members across the country so they can learn how to be good board members. And then every year there's a refresher course or more advanced board essentials for board members that have been there for a while. So we try to keep our board members as educated as possible. We also have monthly webinars that QHR puts on with different subjects to help keep our board members up to date and without them having to travel somewhere. So it's free. It's part of the QHR contract. I'd also like to introduce Bob Phillips. He is our interim CEO that'll be starting here this week. He's also a Bob's very seasoned, and he'll be here until the dust settles with the county, and we'll be able to recruit a more full-time CEO. You like that seasoned word?
Yeah.
Yes, sir.
Mike, I'm a local pastor, and I've been here a little over 20 years. And in that 20-year time period, I've visited a lot of hospitals with our people, from Durango to Albuquerque, Santa Fe, El Paso. And it's my personal opinion, and I will state it like this: this hospital, from your office staff to the floor, to the nurses, to our physicians, to our surgeons, is the best anywhere. I know sometimes in the larger towns they kind of are a little critical of a small town and hospitals, but I want to thank the folks who dedicate themselves to our hospital and to our board, and I'm for one. I want to see our hospital stay in our community and do whatever we can to make sure we keep it here. Thank you.
You need to go to the county commission meeting
I'm sorry?
and say the same thing. When is the county commission meeting such that we could go within the
September 18th.
They changed them to the third Wednesday of the month, starting in September. I think the third Wednesday is the 18th.
At 5:30.
Yes.
Mike,
Yes.
if the hospital, the land, the operations, everything belongs to the county, owned it, they so to speak own it, what do they get back out of it?
Yes, they are basically charged with providing medical care to the county, the citizens of Cibola County. So they operate the hospital, or they charge our board to operate the hospital, take care of the patients in the community. Part of our lease is that the hospital pays the county $265,000 a year, is that right, Jeff?
Yes.
$265,000 a year. What they say is a lease payment or an operation charge for our board to have the privilege, I guess, of managing the hospital.
This is a nonprofit operation, and entire county benefits. Why do they need to charge us to pay? Well, okay. Cost of doing business.
Good question.
Yes, Bob?
Does the county appoint board? I've never quite understood that.
Kinda, yes. Yes and no. The way it works is that whenever there's a certain number of board members that are appointed by the county and a certain number that are self-appointed by the board. Whenever somebody's term is up, if one of the county board members' term is up, then the county presents two people as a possible board member. It could be if the person is an incumbent, and they can do three-year terms. So if they're able to be a board member again, they can reappoint that board member and then put somebody else against them, and then those two names come to our board, and our board chooses one of the two. And then,
Based on ability or preparation, or there's criteria?
there's not really criteria per se. They just, they poll the community, see who's interested in being on the board. And there is a resume that's reviewed, to see if they have some kind of credentials or some kind of knowledge.
Okay.
And then our board does the same thing. When one of the board members' term is up, then we present two replacements to the county, and then in an open meeting, they choose one of the two to be the board member. Also, our chief of staff is automatic board member. So Dr. Harris is the chief of staff right now, and he's a board member until his term is over, then another chief of staff is appointed. We also like to have at least two physicians on the board, so Dr. Patel is also on our board. So we get two different perspectives, so we can have one doctor making decisions that are hospital-wide. We have a good variety. Does that help?
Mike, I'd just like to thank you for your service here. From the time you got here until I guess tomorrow, right, tomorrow?
Yes, tomorrow.
It seems to me, just looking from the outside in, that things have improved greatly along the way. And it seems like it's going in the right direction. So thank you.
Actually, not just me, anybody that's a hospital employee or board member, please stand up. These are the ones that really deserve it. Yes, sir.
Good evening, everyone. I decided to come tonight. I've been watching what's going on with the commission, and I went through that twice. I was a board member for quite a while there. I was a member, a treasurer, and then chairman of the board. So I've gone through this same scenario twice. But I think what we need, you know, first of all, I want to say that if it ain't broke, don't fix it. And this hospital is a gem and jewel for our community. This one and our community college. They're a gem for the community. And I think what we need is we need some bold leadership. We need people to stand up, because if leadership is being bold and doing what's the right thing. And we can't sit back and just watch what's happening. I'm not saying anything negative against the county and that, and I don't know what the motive is, but I just don't understand why they have to do this. Because it's not necessary. We get good service, we have good facility here, we have good employees, you know, we take care of the community and the community going up and down that freeway. That's very critical to us here. And there's no reason to change what we have here. Now, if there was a problem, yes, I could see that we need to have that.
Right.
You know, but I think that we need some bold leadership and stand up for what's right. And I think that has to come, and I'm not saying this in a negative sense, that has to come from the board. The board needs to be bold and be strong out there and stand up to what's going on, because it's just not right. And like I said, I've been through this twice, and through two different scenarios there and what went on. When I remember when I first came onto the board, we paid the county $1. $1. The second time we went around this, that's where they ended up getting $265,000, and they also got $1 million lump sum up front on that. And I remember the board at the time. There's no current board member on there now. There's only 2 of us board members that were against that. And but you know, in negotiation and the numbers you have, you just have to move on. And financially, we were able to do what we did, and it's been going well. No, I'm not saying better than well. And I think we just need to stand up, not only as the board, as administration, as employees, but the community needs to stand up to this and do what's right. And I understand what the commission, you know, they have to do what they think is right, and you know, maybe it takes a little bit of educating of the board, of the commission, as to what's going on here. So anyway, I just want to say that. I mean, I've been watching and reading what's going on in the papers, and I remember one time when they had talked about selling, and I don't think the commission is trying to sell it. I truly believe they're not trying to sell it. I remember when we did that, there was some legislation that was passed in Santa Fe that if it does sell, the first option goes to the city to take over the hospital. You know, and that, I don't know if that worked, but that caused to back them off at the time. Of course, that legislation was pulled back after that I thought. I know it because I wrote that legislation for Senator Joe Pinelli. So anyway, but that's not in place now. But anyway, I just want to say, you know, don't give up. You know, we don't need anyone else to be coming and managing this hospital or running the hospital. I take, for example, I know Quorum used to provide the CEO and the CFO and the, I think, director of nursing for the hospital down in Silver City. They did away with that. They had the same problems that's going on here. Look at that Silver City Hospital. It's been having some problems lately.
They've had big layoffs in that hospital right now. They're laying off a lot of their nursing staff. In fact, my friends work there are without work now because of this kind of thing.
Right. So anyway, I just want to say, you know, you can't give up. You got to fight. It might cost. I know when I was on the board, I remember a lot of you know Tony Esparza, and Patty McClure. You know, when this went on, we fought them. It cost us our positions on the board. That doesn't matter, because what matters is the hospital and that we have it here providing the services. So thank you.
I was just wondering, are we still, the county still collecting the $0.5
sales tax. That was supposed to pay the building off and then get directed into indigent care, new equipment, and all that sort of thing.
Yes.
Yeah.
We also have a mill levy that the hospital benefits from.
I'm sorry?
A mill levy.
Yeah.
Yes.
Mike, how is the reduction or pullback, or is it, I'm not sure really what's, slow community provider fund, how is that going to affect the hospital convention? Because there was a claim in there that because of that, you could have layoffs. I'm not sure that's high enough to have.
Right now, we budgeted $2 to $3 million less this year than last year because of this slow community provider fund cuts. We're still financially sound. Our bottom line, our budgeted bottom line is still going to be in the red. We're going to still be in good shape, or in the black. We're still going to be in good shape financially without that. We do have a good amount of reserves in case something does happen. So there's not really any kind of changes or any layoffs or anything like that on the horizon at this point.
Well, Mike, you rarely find a hospital of this size in a rural community this nice that makes money.
That's exactly right.
Even though you're a nonprofit company or board, you still have to make a profit to continue operations. You have to have operations, you have to have a reserve. Nonprofit is mainly for tax purposes. But you don't find hospitals this nice that make money.
The Medicare is always getting cut, Medicaid is getting cut, and there's more out of pocket, so people have insurance are paying more out of pocket. So I mean, healthcare is changing, definitely it's changing. Maybe not for the better. Well, thank you all very much for coming. I appreciate it. And,